Hello, everyone, and welcome to the Perinatal Collaborative's fall meeting. I hope that you are enjoying this I hope that you're enjoying this transition of seasons into fall. I'm personally really excited about pulling out my fleeces and sweaters and also missing the sunshine. We have three presentations today, and and Kendra is here to help us advance the slides. So presenters, please feel free to ask for slides to be advanced as you need them. We'll have time after each presentation for question and answer, and we will, as always, post the recordings of these slides to our website. We look forward to continuing. Okay, so Kendra, would you go to the next slide, please? So today our presentations include my welcome, and we will play a land acknowledgement. I want to say also before that land acknowledgement that it is more than just a video and a gift from the Puyallup tribe to share with you and recognize the land of the Puyallup peoples that we're on, but we also, in our effort of mitigating disparities in perinatal health and the impact on parents, specifically women, and also trans and non-binary people and our babies, we also need to recognize the toll of the laborers and forced labor that built this land and built the institutions that we have benefited from. Okay, so I will show a video in just a moment, but we're also going to be joined today by Kate Cranfield and Annie Tu from the health department, who will be giving an update on childhood vaccines as we go into fall. We're then going to be joined by Alissa Copeland from the Department of Children, Youth, and Families at the state, who will be talking about Plan of Safe Care and how we support families with opioid use disorder. And then we'll be joined by Emma Plazola from Virginia Mason Franciscan Health, who will be talking about how they have integrated a really beautiful evidence-based practice called Eat, Sleep, Console, or Eat, Console, Sleep on as an alternative way to support children that are going through withdrawal from opioid disorder exposure. So next slide, please. And you can go. General guidance for the meeting. If you are not talking, just to help with our bandwidth, if you could keep your camera and mic off. We hope that there will be time for speakers to take your questions. Feel free while they're talking to put those questions in the chat, and I'll make sure to read them and bring those questions into the presentation. And as I said, we are recording today's presentation, and we will post it to the website, which is tpchd.org/PCPC. And if you just happen to be forwarded this invitation and would like to come to other of our quarterly meetings, you can sign up for our announcements at our webpage. We do have an exciting conference coming up on October 21. It will be in person, again, at the Eastside Family Resource Center as last year. We have some really incredible speakers and a panel. There's going to be lots of time for networking and snacks, and we hope that you will join us, and you can get more information from that by signing up for our announcements on our website. Next slide, please.
It is the land right here that the Puyallup people have lived on since the beginning. This
right here is where we are in the world, our homelands.
We work on our ancestral lands. We raise our children who go to school on the land of the Puyallup people.
Ohei gwed chas ti shwananam tliti, ohalshitub ti pasted okweredu.
We acknowledge that the Medicine Creek Treaty was signed for the whites to take our land for their benefit.
Ochalshitub chas, ati shunanam tliti ati swat we've put chas. Otuk ti pasted, squat lup swat we've put lup. Land
was assigned to our people. The Caucasians said, "This is your land," and they took that land from us too.
Okararitub chas atiswa twipud chas. Odzak atub tis kliti.
Our land was stolen from us. Treaties were broken.
Toch didi chas a tislachel.
But we are still here today.
Hui chasa tu kwelin, chasa tu ish, chasa tu alalos, chasa tu tol shot sidam.
Our people forage for food and materials, we pick berries, we canoe, we practice our traditional ways, and we speak Twelshutsi.
Just as our ancestors did.
Hoya chas.
We are finished.
All right, I'd love to welcome Annie and Kate.
Hi, good afternoon, everyone. My name is Annie too, and I am a public health nurse at the Tacoma-Pierce County Health Department, and I work in immunizations alongside my colleague, Kate Cranfield, who unfortunately last minute could not make the meeting, so you get just me. But I will be reviewing the 2024-2025 respiratory season vaccine recommendations. Next slide. So here's a brief overview of what I will be covering today. I will be going into the specific recommendations as far as RSV vaccine, the flu vaccine, and COVID-19 vaccine, and which products are available for those specific diseases, and also where they can access vaccines. And I will also be reviewing some childhood vaccine promotion materials that we recently developed. Next slide. All right, so first I'm going to talk about RSV vaccines or immunizations that are available. So RSV is a respiratory infection that for most people, it's mild with cold-like symptoms, but for a few populations, especially infants and older adults, they're at higher risk for severe disease. And then for infants is the #1 leading cause of hospitalizations. So there are 2 different RSV immunizations that are available to protect infants and children. First one is nirsevimab, trade name Beyfortus, and this is a monoclonal antibody that is given as a single dose and is recommended for infants birth through 8 months old that are born during the born during or entering their first RSV season. And typically for most of the continental US, that's typically October through March. It is also recommended for toddlers 8 months to 19 months who are at higher risk for severe RSV. So that includes, kiddos with chronic lung disease, cystic fibrosis, American Indian, Alaska Native, and those who are immune compromised. So the availability of nirsevimab should be at all birthing hospitals in Pierce County, as well as pediatric offices. And then nirsevimab is part of the CVP program. And then if you guys were around last year, many of you know that last year nirsevimab was in short supply, so not all infants that wanted it could find the immunization. So this year, as far as we know, there should be adequate supply for the 2024-2025 RSV season. Second option for protection for babies and young children is through maternal vaccination with Abrysvo. So that's given as a single dose, recommended for pregnant people who are 32 to 36 weeks gestation, and administration months are September through the end of January. So, right now the CDC recommends either Abrysvo or nirsevimab. Most infants won't need both. So if the pregnant individual does get the Abrysvo, and it's within 14 days before birth, then they don't need to worry about getting their infant the monoclonal antibody. Abrysvo is part of the CVP program for those individuals who are 18 and under who are pregnant. That should be available to them through that program. Otherwise, Abrysvo is available at select pharmacies and clinics, and they can use the link below, which is the Abrysvo vaccine finder. Next slide. There's also RSV immunizations for older adults. 3 products are available. There's Abrysvo, Arexvy, and a new one that's out this year, Mrezvia. It is recommended for everyone 75 and older should get the RSV vaccine. And then also for adults 60 to 74 years of age with increased risk of severe RSV. So that includes, people with heart disease, lung disease, cancer, immune compromised conditions, those that live in nursing homes, long-term care facilities, and any other health condition that puts them at higher risk. The best time for older adults to get the RSV vaccine is now. But it's not an annual or season specific. So, anytime that the vaccine is available to them, they should get it. And it is available at many pharmacies and some clinics. And then I do want to indicate here that Arexvy and Mrezvia are not approved for use during pregnancy. It's only Abrysvo. Okay, next slide. All right, then I'm going to move on to flu vaccines. So flu vaccines is recommended for everyone 6 months and older. It's very important to, prevent complications from flu, and then that can lead to hospitalization, but especially important for pregnant persons, adults 65 years and older, individuals with chronic medical conditions, and also for children 6 months to 5 years. The best time to get a flu shot is before October, before really we're in the swing of respiratory at this peak. But it's never too late to get that flu shot if it is later in the season. And they should be available at most clinics and pharmacies. Next slide. All right, now we're going to go over COVID-19 vaccines. So the 2024-2025 COVID-19 vaccines is available now at most pharmacies and some select clinics. It is recommended for everyone ages 6 months and older. Infants and young children may need additional doses, and that's really dependent on their vaccine history and what vaccine type they got. And then there are 3 different products. So there's Moderna and Pfizer, which is approved for 6 months and older. There's also Novavax, which is available to those 12 years and older. Best time to get the vaccine is by the end of October, similar to the flu vaccine. And like I said earlier, it is available at most pharmacies and some clinics. Next slide. Okay. Well, for the takeaway for the vaccines, I just want to, encourage those that work with families or even for yourselves to, get the vaccines available to you, because we know vaccines are one of the best ways to prevent, severe complications from disease that can lead to hospitalization. So really encourage you to have those conversations with your families, to encourage them getting those vaccines. All right. So next, I will be reviewing some childhood vaccine promotion materials that we recently developed. And this is really in response to the vaccine rate. So it took a dip, during the pandemic, people weren't bringing their kids into the doctor's office, or it's hard to get in. And so we really saw a dip in vaccine rates. And so we wanted to develop materials to kind of help bring awareness to the importance of vaccines, answer questions for families who may be hesitant to get their kids vaccinated, or also for those who are experiencing some vaccine fatigue. And so we collaborated with the home visiting nurses at the health department, as well as some community partners to develop, culturally relevant materials. So next slide. All right, so the first one is a FAQ for families. So we really, like I said, we collaborated with different community partners, as well as the nurses at the health department, also worked with parents in the community to really understand why, what are their most common questions that they have surrounding vaccines. So, there was a common theme about which ones are frequently asked. And so we wanted to make sure that those were addressed in the FAQ. So just some examples of, things that are addressed, why vaccines are important. A lot of the questions are about, does vaccines cause autism? And also, why does my child need so many vaccines? So we really addressed it here. These are just examples of 2 of the pages. Next slide. And then we also have an FAQ for childcare providers. So, working, collaborating with them, we learned about what they really need to know as far as vaccines and vaccine recommendations and requirements. And so we wanted to have it in one document for them. Next slide. Another thing that we learned is because parents weren't bringing their kids in too frequently, or, they have several children, so it's hard to keep track of when and what vaccines their child may need. We wanted to develop an easy to read vaccine schedule. As you can see here, we designed it so then, they can look at the ages of their child and kind of mark off what their child received, and they can see what is upcoming, so they know to ask for that, and they can do their own research. We also developed that into some magnets. We have limited quantities of that, but just an easy tool for families to put in their fridge so they can keep track of their children's vaccines. Next slide. This is a vaccine through history kind of document that we developed, and we learned, a lot of parents are hesitant because, especially after COVID, when it seemed like these vaccines were being developed really quickly. So that kind of contributed to their vaccine hesitancy, especially around COVID vaccines and other vaccines. And so we wanted to kind of highlight, over time, what the development of vaccines have been through time, and that these are not new, technologies that are being used to develop these vaccines, and that it's shown to eradicate or kind of reduce the numbers of vaccine preventable diseases. Next slide. We also created these coloring pages, which we, obviously wanted to emphasize the importance of vaccines, but also other measures to keep everyone healthy, like washing your hands, covering your coughs and sneezes, and staying at home when sick. There's also a poster that we created kind of along the same lines. Next page. Next page. All right, so a lot of the FAQs, all the documents are available in multiple languages. And so, you're working with families with different, that speak different languages. We have them in English and also the 12 most commonly spoken languages in Pierce County. We do have, they're available to order, so we can do the bulk ordering for you if this is something that you would like to use in your practice or in your work to distribute to families. You can go ahead and click on the request form, and you can request, which documents you want and which languages, and we can get those to you. And if you'd rather there are printable PDF versions that you can access anytime in the different languages on our website that you can print. Next slide. All right, so that is the end of it. So if anyone has any questions, would be happy to answer them. If you think of any questions afterwards, here is our contact information. Please feel free to reach out if you ever have any immunization questions.
Thank you so much, Annie. Anyone want to raise their hand and ask any questions?
Oh, I see. Are these on the website now? Yes. So if you click on the link once the PowerPoints are shared out, or you can go to tpchd.org/kidvax. The documents are out there for you to access and print, and they're available in multiple languages, but also will be linked in the PowerPoint where it says PDF printable forms.
Did you say /kidvax?
Yes, KidVax, so KIDVAX. KidsVax, sorry. My bad.
KidsVax.
Yes.
I'll edit it.
I only access it each day, every day, but ask me, I'm leading people wrong. So yes, thank you for that edit.
Cheers. Thank you, Annie.
Yeah, you're welcome. Thank you for having me.
We really appreciate you being here. All right. Alissa Copeland is here from the Department of Children, Youth, and Families to talk about Washington State Plan of Safe Care. Alissa, are you with us?
I am, yes.
Wonderful. Thanks for being here.
Absolutely. Thanks for having me. And I do want to make sure I have two of my colleagues from within reach that are joining to talk about our work specifically in Pierce County. So I want to make sure that Kate and Camille, oh, yes, I see them. Okay, good. Hello, hello. All right. Should we just go ahead and get started?
Yeah, thanks.
Absolutely. So thanks for having us. We're going to talk about Washington's plan of safe care work. And then, like I mentioned, we wanted to share with you guys the really unique and specialized way that this work is happening specifically in Pierce County as well. So I'm going to go ahead and provide an overview of what the plan of safe care is. Next slide, please. So the plan of safe care is federally required in federal legislation for what used to be exclusively in child welfare. It is a component of the Child Abuse Prevention and Treatment Act. But in when the Comprehensive Addiction and Recovery Act was enacted in 2016, there were some pretty significant changes to the plan of safe care. What those changes essentially covered was it expanded the population requiring a plan of safe care to include families who didn't necessarily meet criteria for child welfare intervention. It required that the plan of safe care be utilized and viewed as a family-centered plan, whereas before it was really viewed and utilized as a plan just for that infant who'd experienced prenatal substance exposure. And it clearly defined structure for families to access community-based services and resources alongside the services and resources that families experiencing a child welfare intervention might access. And I should say right off the top, the plan of safe care is a plan for newborns who've experienced prenatal substance exposure. Next slide. So when this all happened back in 2016, we as in Washington, were one of the first states to jump on board with implementing the changes. Once we got the instructions from the federal government and were connected with the nationwide agency, the National Center on Substance Abuse and Child Welfare, that would be the TA provider for states, we got going. And so our initial work was to define the language in the federal legislation for Washington. The federal government left quite a bit of leeway for states to have a lot of flexibility in how they defined who requires exactly a plan of safe care, so what kind of prenatal substance exposure, and how plans of safe care will be administered. So there's a lot of leeway, which means that we had to come together as a state and figure out how we were going to do it in Washington. We had to identify criteria for pathway determination. The large work group that worked on this initial development had decided early on that they would keep the child welfare kind of traditional pathway for families to receive a plan of safe care, and then also add a community-based pathway for those families who don't meet the criteria for child welfare intervention. So we had to identify how we'd figure out what those criteria would be for the pathways. We had to support a shared understanding of the plan of safe care body of work across many systems, recognizing that this is about child welfare and community-based organizations and birthing hospitals and substance use disorder practitioners and kind of everyone else in between that might be working with a family who's experienced perinatal substance use disorder. So we wanted to have a really shared understanding of what this work looked like across all of our systems. And then we had to develop and implement some cross-system structure to really bring forward implementation of the plan of safe care work. So I'm going to talk a little bit about how that played out, and then you guys will hear where we are now. So next slide, please. This just goes over our implementation timeline. I won't go into everything in detail, but you can see that we piloted our first two sites, Yakima and Pierce County, in June 1st of 2021. And then we had essentially launched the ability to offer the plan of safe care statewide beyond those two pilot communities by December of 2021. We did a lot of work implementing and learning from early stages of implementation, getting hospitals onboarded, developing an external to DCYF online referral portal, and working across all our systems. And I'll talk a little bit more in some upcoming slides about what those systems are. And then we're at a point now where we're just continuing to scale to state. We have a goal of 100% of birthing hospitals onboarded this calendar year. We, with our partner agencies in this work, sent out a cross-agency letter a little over a year ago that requested hospitals update their policies and procedures to align with the Plan of Safe Care body of work by January 1st, 2025. And we also have been focusing on increasing community partnerships, supporting long-term recovery, and really making those longer-term connections for families in communities across our state that are accessing the community-based pathway, and hopefully also as a possibility to make those connections upon case closure for those receiving a plan of safe care in the child welfare pathway. Next slide. So this slide really highlights all of our cross-system partnerships in this work. We've worked really closely with folks at the Department of Health, the Healthcare Authority, the Washington State Hospital Association, and with our community-based organization partner within REACH. And what that has really led to is these wonderful cross-sector partnerships that are driving the work and standing up and supporting not only the Plan of Safe Care itself, but several aligned bodies of work. For example, WISH's Safe Deliveries Roadmap Initiative and Department of Health's Center for Excellence certification for birthing hospitals for perinatal substance use disorder. So all of this aligned work is happening in partnership and is very much connected to the Plan of Safe Care body of work. The maternal mortality review panel report to the legislature, the most recent one dated January 2023, identified the Plan of Safe Care as a promising practice across the state to reduce maternal mortality rates. We're supporting hospitals with their policy templates for updating the policies, like that letter is requesting they do. We are a component of Washington's opioid and overdose response plan. So identifying that engaging in the Plan of Safe Care and aligned or related bodies of work is identified as best practice to support families experiencing substance use disorder in general, and then of course the impacts of the opioid epidemic. We've been able to develop infrastructure across systems, and like I mentioned, we have an online referral portal that sits external to any of our state agencies. And we've taken the opportunity most recently to make enhancements to that online referral portal as we've gathered some user experience data. We've learned from areas that maybe we could have further clarified things in earlier implementation. So we're making enhancements as we go so that this process runs as smoothly as possible for those who are players in the referral portal and making these connections for families to a Plan of Safe Care. Next slide. So this slide essentially shows what all of that early work decided in terms of the federal definitions for Washington and who needs a Plan of Safe Care. So for Washington, it was decided that newborns who've experienced prenatal substance exposure, newborns who are affected by withdrawal symptoms at the time of birth, or affected by the range of effects identified by fetal alcohol spectrum disorder or known prenatal alcohol exposure should have a Plan of Safe Care. And so families meeting these criteria will receive a Plan of Safe Care in the community through our Help Me Grow network, or from DCYF if there's an open CPS case and they meet the criteria for child welfare intervention. Next slide. So this provides a real high-level overview of how that online referral portal works. Essentially, a birthing hospital will identify that an infant has experienced prenatal substance exposure. They provide some de-identified data because, of course, we are collecting as a state data about this population and prenatal substance exposure. And we also have some data that we're required to report to the federal government. If a report is needed to DCYF intake, what will happen is the online referral portal's algorithm will direct the provider to call DCYF intake. That algorithm consists of 4 brief questions that really get at specific family circumstances and helps determine the appropriate pathway. It really helps identify if that family is likely or not to meet the criteria for child welfare intervention. So if the community-based pathway is appropriate, if the portal's algorithm identifies that the family likely would not meet criteria for child welfare intervention, the referrer from the birthing hospital is sent directly to the referral form to refer that family for Help Me Grow, for the voluntary community-based pathway. Once that happens, Help Me Grow will reach out to the family and refer them to services and other wraparound supports. And then I didn't mention when I was talking about the child welfare pathway, but as far as making connections to services and resources on open child welfare cases, the plan of safe care is just another component of the overall work with the family, their case plan, et cetera. Next slide. All right, so I'd like to go ahead and hand it over to Kate and Camille from Within Reach, because we did some really, beyond your community being one of our pilot sites, we did some really great work to really inform how we'll expand in communities across the state, working in partnership with local networks.
Yeah, thank you, Alissa. I will kick us off for the Within Reach or Help Me Grow Washington side of things. And just to briefly introduce myself, my name is Kate Ajayaboa, and I'm the Perinatal Partnership Manager at Within Reach. So I support hospital trainings with the Plan of Safe Care and relationship development. And we have a great relationship with South Sound 211 and have been working with them to figure out what Plan of Safe Care looks like specifically in Pierce County. I also live in Tacoma myself, so there's that. But we're going to talk a little bit more about what the community-based pathway looks like, and then Camille will follow up with more details. But currently, what makes the Plan of Safe Care community-based pathway unique is that it's exclusive to birthing hospitals. So in order to reach this specific pathway and through the Plan of Safe Care, the specialized mental and behavioral health team, currently that is available only through birthing hospitals. So a provider at the hospital has to make that referral currently, and it has to happen postpartum, but before the family is discharged from the hospital. We're hoping to have a self-referral pathway someday and other kind of opportunities, but currently that's what it looks like. And then the Plan of Safe Care families get a different outreach and follow-up structure than general Help Me Grow support. So it's a little bit more robust and a little bit longer term. And then they get a focus on the unique needs of a family with SUD exposure. So our mental and behavioral health team has specialized training for this, serving this population. They do a lot of workshops and special continuing education opportunities, a lot of things through Perinatal Support Washington and the Brazelton Touchpoint Center, for example, and just really try to have robust resources and supports available to offer these families. Yeah, and then I think Camille will share a little bit more about the specifics if you want to move on to the next slide.
Yes, thank you, Kate, and hello, everyone. Good afternoon. My name is Camille Schultz. I use she, her pronouns, and I am the supervising coordinator of the mental and behavioral health team at Within Reach. And before I fully launch in, I do want to recognize the uniqueness of Pierce County within Plan of Safe Care. Because like you saw on Alissa's timeline slide, Pierce County was one of the original 2 pilot sites for Plan of Safe Care. So there was Pierce County and Yakima County. And in Pierce County, like Kate mentioned, it's South Sound 211 or United Way of Pierce County that holds that local Plan of Safe Care site, right? Because we're not in a pilot state anymore. We're a full-on program. But South Sound 211 still holds that local Plan of Safe Care site. So I supervise the team that takes on statewide other than, right, outside of Pierce and Yakima County. So I just want to clarify that. And when referrals come through the portal and land in our queue, if we see that that client is residing in Pierce County, we transfer it out via encrypted email to South Sound 211 or United Way of Pierce County. So we work in close collaboration with them, and then they take on this process in this direct service component, but it's exactly the same, right? When we talk about plan of safe care and the community-based pathway, we want it to be the same structure throughout the state. So after a referral form is submitted, like Kate said, by a birthing hospital provider before the birthing parent has left the birthing hospital, that is our phase 1 of Plan of Safe Care statewide, because we need to get all of these birthing hospitals onboarded, right? Just like Alissa said, before January 1st of 2025. So that's phase 1. And then we can open up into different pathways. And we've been in a lot of talks about that. But regardless, so after the referral form is submitted and we get that transferred over to the Pierce County team, one of their specialists will reach out to that patient who becomes their client within 48 business hours. So it's a pretty quick turnaround. And typically that birthing parent is still at the hospital, still in the hospital bed, and we don't always get engagement on that first call, text, or email. So that specialist will make up to 4 total attempts to connect. So that first one is within 48 business hours. All of the other ones are within 2 weeks of each other. So you can see there that outreach window is pretty wide. That's a little bit less than 2 months of trying to engage with this birthing parent. And if and when they get them on the phone, they will go through an intake and social needs screening. So confirming and identifying any demographic information, and then really going into a screening process that's prompting and probing for perinatal SUD needs as well as basic needs. Because what we're finding is that people really mostly need help with things like housing, food, and financial assistance, as well as baby supplies, paid family medical leave, and yes, mental health counseling, treatment options, but knowing that this pathway for community-based pathway is so specific. Just to kind of name specifically the types of clients that are coming toward the community-based pathway, that is exposure to MAT, right? Medication-assisted treatment, prescribed medications that have been taken as prescribed, or any medications that have abuse potential that were taken as prescribed, or cannabis, all with no safety concerns. So you can see here, that is a smaller piece of the pie, right? So just to let you know, not a lot of our clients are already engaged in treatment. They're already on MAT. They're more so needing that parenting support, that basic need support, so that they can bring their stressors down, be on their recovery journey, and keep their baby at home. So just to kind of lay out what that looks like. So within this screening, we're leaning into strengths. What do they already have? Where are their gaps? And then we plug resources into those gaps. And the specialist will provide resources and offer warm handoffs based on those gaps and whatever's on top for the family, right? We are just their helper. And this is all consent-based, right? So at any point, if they're like, I have all the help I need, or you know what, this is a little bit overwhelming, I'm bringing baby home, I'm coming up for air, I'm finding that I have just a little bit of time in the day for me, we're like, hey, that's okay, right? It's all to be of service to the family. And we always like to highlight the importance of warm handoffs. We are not just giving out phone numbers and hours of operation, right? This is tangible resource connection. We're calling ahead, we're calling on behalf with consent, we're calling with the client just to ensure that they got connected to these resources successfully. And then after that, the specialist will check in 4 times, each 2 weeks apart. So again, about 2 months of follow-up. Hey, how did that diaper bank work out? Hey, we knew that you were eligible for paid family medical leave. Did you do the application, or did you call ESD, right? Just really kind of getting into that and following up on resources again to make sure that there was success. So that's what the process looks like at a glance, with some good details in there. Next slide, please. Okay, so you may be wondering, okay, you've named a couple of resources, but what is the scope here? The scope is wide, I would say. So you can see over here on the left-hand side, we have Help Me Grow general support. So that's application assistance for benefits, basic food, Washington Apple Health. We can add baby onto either of those. Housing resources. We know it's a huge need in the state, huge need in Pierce County, right? We will do all that we can to connect clients to short-term, emergency, long-term rental assistance, utility assistance, whatever they're needing help with, knowing that that's a cornerstone to their recovery. Home visiting, PCAP. PCAP is the major home visiting program. We're well trained on all home visiting programs, but being that PCAP, Parent-Child Assistance Program, it's tailor-made for this client community, pregnant and parenting people with SUD. Early intervention resources, knowing that prenatal substance exposure is automatic eligibility for ESIT. This is always on the table. However, we want to make sure that the family's ready so they know that the option is there when they're ready for that referral placement. Parenting supports, warm lines, hotlines, virtual in-person groups, right? Whatever they're needing there. Childcare Aware is the main expert around the state. So we really lean into them. Baby supplies, right? Diapers, clothing, strollers, car seats, huge. And then coming over here on the right-hand side, additional MBH support. So that's the SUD assessment or treatment. Recovery coaching, peer mentorship. We partner very closely with First Legal Clinic. Mental health resources, again, that can be, support groups, therapy, whatever they're needing there. Postpartum depression support also falling under that umbrella. Safe sleep and purple crying information, we're providing that information or connecting them with Seattle Children's. Intimate partner violence support, and then lifeline phone services, knowing how important it is to have a cell phone that has minutes and has access beyond Wi-Fi so that they can keep up with their resources and all of their support network. So again, this is not exhaustive. Our scope is wide. We will do all that we can to connect clients to resources, but here's what it can look like for us as we assist clients in Pierce County. So that's my last slide. So I'll go ahead. I think we can open it up for questions. I see that there's some things that have been going on in chat. So Alissa, not sure if you want to circle back, or Kate.
Yeah, excuse me. I'm happy to. I answered the 2 questions that popped up in chat, really around kind of those criteria for each pathway. And I think that the example given in the question of a baby born to a parent who's been on methadone, in treatment, actively in recovery, that is an excellent example of family circumstances that are appropriate for the community pathway and would not meet the criteria to screen in for child welfare intervention. And so that is kind of the critical piece about this body of work and getting all of our hospitals onboarded and understanding the 2 pathways and those type of criteria, so that when they use the online referral portal, in addition to that being the location where we're collecting a lot of really important data at a statewide level, it's also the place where that pathway is determined. So that's the critical piece of making sure that all of our partners in this work have a good understanding of how that works at the time that the baby's born. And then there was another question too from a DSHS staff about how to make sure families are connected. And I think right now, as Kate said, the primary or sole referral pathway is from birthing hospital to either DCYF intake or to the Help Me Grow referral. So we don't have any referral pathways beyond that yet, although that is a future goal for this body of work for sure. But I think the best way that DSHS staff working with families who are experiencing substance use in pregnancy could get a family connected with this work is provide some education. So I put some resources, DCYF resources in the chat, just so that folks understand what the plan of safe care is, that there are two pathways, that this pathway determination happens at the time of birth. And then, of course, the more services and especially SUD treatment options that we can connect pregnant people with prior to the birth of the child, the higher chances are that they won't meet child welfare criteria for child welfare intervention at the time of birth. So the more, for example, the more stable in treatment and recovery services, the better chance they have of being an appropriate circumstance for the community pathway when that baby's born.
Alissa, I think there was another interesting question just asked about a person that's still pregnant and experiencing exposure. I don't know if you want to clarify that or mention the hub, or maybe that's a whole nother conversation.
Yeah, I'm happy to mention it, especially because we do have providers in Pierce County. We do have another pathway that is related to our plan of safe care work, and we partner with the same wonderful folks at Within Reach, and it's called the Pregnancy SUD Pathway. And that is another way that pregnant people can be connected to community-based services, get engaged in treatment while they're still pregnant. That referral pathway would be through DCYF intake. We do not screen in. When we receive an intake with concerns about pregnant people, we don't screen in for an open child welfare case until a baby is born. So those are automatically screened out. But we do have 9 counties across the state where we are partnering with community providers who then will attempt to engage a pregnant person. When we send them that screened out intake, they'll attempt to engage that person in treatment services and resources. And so if you are a provider who's working with a pregnant person and you want to get them connected, I would say the best course of action would be to make that call to DCYF intake. We do have a really strong relationship in Pierce County with South Sound 211, who's providing this work, and also in Kitsap County, which is Kitsap County PCAP. And so what would happen is we would send that screened out intake over. But one of the things that is really beneficial is when the provider who's calling DCYF intake gives permission for their name and contact information to also be shared with the community partner. Because we, as you can imagine, especially in the roles where you all are working, it is much easier to engage a pregnant person in services when we have that link of the person who is wanting to help them get connected. And so our DCYF intake folks should always be asking, do I have your consent to share your name and contact information with the community agency as well? And so I always encourage providers to say yes and help with that engagement and connecting that pregnant person to those services.
There's one more question in the chat, Alissa. Do you want me to read it aloud, or you got it?
Is it the one about hospitals getting trained?
Yeah.
Yeah, kind of the same process. So we haven't done a lot of training or outreach to hospital emergency departments, aside from a little bit of kind of testing in King County with some local hospitals there. But that is definitely on deck in the longer term goals of this larger body of work, and specifically for the pregnancy SUD pathway, is to be able to have a more direct referral pathway from places like emergency departments, especially hospitals that have OB, EDs, and other providers who might be working with pregnant people. So hopefully there will be some news in the future that we are be able to expand that direct referral pathway. But right now, for the pregnant folks, that pathway referral is only available via DCYF intake.
Thank you all so much. This was really, really helpful. The work you're doing to protect these families is phenomenal. We love the way you're working with our partners here in the county, and thank you.
Yeah, thank you all for having us.
Last but not least, we have Emma Plazola from Virginia Mason Franciscan Health, who's going to also talk about how we protect babies that have been exposed to opioids in utero, and new evidence-based strategies to promote an easier transition into the world. So, Emma, you're up. Thank you for being here.
Awesome. Thanks, Jax. I'm excited to be here amongst really excellent colleagues. I was really loved the last two presentations. So hi, everyone. I'm Emma Plazola. I am the perinatal safety specialist currently at St. Francis Hospital, which is like a quality improvement nurse position. But most recently, I was a regional neonatal educator in our system of hospitals. And so I helped with the rollout for Eat, Sleep, Console in our system. And I was also actually helping this as I was a staff nurse transitioning into this role. And so I have kind of an interesting viewpoint from all three perspectives on the quality data side, the actual implementation of how this rolled out for our staff, and what it was like to take care of these families on the floor, on the inpatient floor. And so they asked me to just kind of present how this sort of project rolled out in our system, and as an example of how we can better care for these families. Go ahead and start for our first slide. So you all know a lot of this, and it's cutting it off a little bit, so I'm not sure if you all can see the whole slide. Apologies for that. I think it must have been the conversion from Google to PowerPoint. But there's a really significant need is the whole point of this background. There's a few slides about this saying that, and this isn't even really recent data. This is, what's been published over a decade ago. But there's a huge prevalence of this in our community. It's nationwide, but specifically in the Tacoma-Pierce County environment within Washington State. And the majority of pregnancies that occur among women with opioid use disorder are unplanned. And so it's one of those things where we tend to be the first touch point in the inpatient side of how we can help care for these families as a whole. And it means there's generally not a whole lot of understanding of what this will mean for their baby once they're born. There's a lot of fear and anxiety that these patients experience. And so if you don't mind, go ahead to our next slide. It's a huge issue, and it's not something that just, the parents are struggling with. These babies have a tough time in the first, week or two. And the way we were caring for them before using, Finnegan scoring and scheduled morphine really wasn't helping them live their best lives. And so the thing that I love about Eat, Sleep, Console is it really focuses on maintaining the family unit, implementing the parent as the primary caregiver, and also really focusing on how can we help this baby be well, right? And a lot of that isn't about monitoring every little symptom. It's really about, can they do the things they're supposed to do as a baby? But it's a huge issue, right? We know like a lot of babies are born being opioid exposed, especially nationwide, and it's about every 25 minutes. As of 2015, it's even more, I believe now, but I couldn't get that image in before our slides were due. Go ahead and move forward. So it's a huge increase in our nationwide issue, but specifically in our community as well. 5-fold increase in the US from 2000 to 2012, and about 8 or 9 people per hospital births will be experiencing this, 8 or 9 families. And so clearly this was something that wasn't going away, right? We needed to address. And I think we just weren't doing what was best for our families before. We were doing a lot of, treating symptoms, looking at it as a pharmacological, issue that needed to be managed. And in that way, a lot of ways we were extending the stays at our NICUs for these families and not really giving the parent that primary role as the caregiver for give them the opportunity to be empowered to provide care for their babies. So we started to look at, okay, what are our best practice recommendations? Advance to the next slide, please. And pretty much everyone agrees that the elements of Eat, Sleep, Console are really the best way to go about caring for these families. So emphasis is on, AAP says non-pharmacological support first, cautions initiating pharmacological treatment, because as we know, opioids are not without some challenges. Prolonged exposure is not what's best for babies' brains and for their neurological development. Vaughan as well really promotes parental engagement, avoiding separation of that dyad, that birthing parent, baby dyad, and engaging parents in providing those interventions for them as a first-line therapy, not as adjunct, right? As they are the primary therapy. ACOG also agrees that early universal screening and coordinated multidisciplinary approach without criminal sanction, so a supportive way to care for these families, is the best way to do this. So our system, a couple of people in our system were really inspired. They heard about Eat, Sleep, Console at a conference. Specifically, Heather Olenek, she was like our champion for this. She actually helped develop the program for Eat, Sleep, Console at the national level for Calm and Spirit Health as well. But they were like, we can do better. This is something we really care about. We know that our families are really struggling, and we can see that we're not really providing them holistic care. And so we decided to look at specifically the Eat, Sleep, Console method. If you don't mind moving forward to our next slide. So let's talk about what it is specifically. I don't want to assume that everyone knows that here. We'll go over it briefly, but it's basically looking at how do we support our babies' ability to function or their activities of daily life. How can we help our babies be babies, right? So does this baby eat well, right? And whether that might look different if they're preterm versus term, but it's essentially, do they eat enough volume at a regular enough interval? We're not going to put them on a feeding schedule. We're not going to treat them immediately like a NICU baby. We're going to let them ad-lib feed and show us if they're able to maintain that function. Next question is, do they sleep, right? That's a huge challenge with our babies that are opioid exposed, but if they're able to sleep for over an hour after their feed, that's considered acceptable amount of sleep. And the last bit is, can our babies be consoled? And that's, just like any normal baby would cry, but can they be consoled within 10 minutes using, all the different techniques that we help teach our parents? So these are essentially the tenets of Eat, Sleep, Console. Like, can our babies be babies? And where does this come from? So we want to hit our next slide. This comes from it's also called the Yale method, but it was developed by Dr. Matt Grossman and his entire team at Yale back in 2012. And so their baseline was that about 5% of their NICU beds were filled with now babies. And in some community hospitals around them in their area, it was as high as 50% of the beds were filled with now babies, and a really long average length of stay. So 3 weeks is pretty significant, right, for these families. And 3 weeks is also a really significant amount of time for a baby to be on opioids, prolonged opioid exposure, because that's basically what the treatment used to be. It was just start them on morphine and wean very slowly over a long period of time to reduce symptoms. So they found that NOWS was actually the longest length of stay in general in pediatrics, next to prematurity, which is impressive. So we're looking at, can we do better for these families from a care perspective, but we're also looking at, that's a significant cost, right? If we have a really long length of stay, that's not necessarily what's best for the patient and isn't the best use of resources. And so their team, Dr. Grossman, developed Eat, Sleep, Console and implemented it. And at Yale and at a bunch of different community hospitals. So let's take a look at whether or not it worked. Hit our next slide. Pretty much the resounding answer is yes. It's really, really effective. At all of these hospitals, these examples, morphine was used very much less frequently, only really when as needed, most often as like a PRN dose as needed for ESC scores elevating, and they just needed that one dose to help their brain get over that really difficult period of time. And then they were able to just make it with those non-pharmacological interventions. But I mean, look at the morphine use reduction is huge. So, I mean, reduced by 79 to 84% at all of these different sites. What we found interesting is there wasn't a ton of data out there about reducing length of stay. And so that is something we wanted to put into kind of our project design to make sure that we're looking at, okay, are we giving less morphine to our babies? But also, are they not being there for a really long period of time going through a withdrawal without morphine? We wanted to kind of make sure that those are balanced as well. So the other piece of this we really wanted to look at was, is this method better for our families? Not just does the baby get less morphine, right? But does this actually improve our assessment of this baby's condition and whether or not we can keep these families together? So that was the next piece we wanted to look at before we rolled out our implementation. So if you want to hit our next slide, please. So we used to use the Finnegan score, which was historically, I mean, I think everyone was using Finnegan to assess for, neonatal abstinence syndrome or neonatal opiate withdrawal. And the downside to Finnegan is it didn't have a large body of evidence that specific assessment tool was the best way to do it, but there was just no other way that anyone was doing it for decades. I mean, Finnegan was created, I believe, in the 70s, like 1979. And the challenge is we were really just looking at reducing symptoms because Finnegan's scoring was all about, how many times the baby sneezed and whether or not they had tremors and all these things that would be typical symptoms of going through withdrawal. But it didn't really assess the baby's ability to function, right? We're just looking at like adding up all of their symptoms. So the Finnegan scoring was really just about suppressing those symptoms, that the NICU is, the NICU caregivers are really the nurses, and the treatment team, they're not really involving mom as the primary caregiver, or birthing parent as the primary caregiver. They're really looking at the numbers. So like, is that score increasing or is it decreasing? They would say feed on demand, but we all know in a NICU environment, quite often if the baby is admitted to the NICU, they kind of end up on a NICU schedule, just because that's part of the culture of the unit. And so quite frequently, they wouldn't always be fed on demand. It would be kind of more scheduled. Morphine was definitely the first line care, right? So if the baby's score was elevated, they initiated oral morphine, and they captured the baby at a fairly decent dose, and it took a really long time to wean off of that. So the way that Eat, Sleep, Console kind of flips that methodology is that we're just looking at our baby. How can we help this baby be a normal baby, right? We're going to maintain that diet as much as possible because that's what normal babies need and want to do. We're going to make sure that we're treating the neonate, right? Like whether or not their ability to function. We're not going to look so much at this whole suite of symptoms, which they might still have some of, but if they're able to eat, they're able to sleep well, and they're consolable, that's all that they really need to be comforted. And we're looking at providing that supportive care. And by we really mean the primary caregiver, meaning the birthing parents. We don't have any feeding schedule. The baby's ad lib, so whatever they need is what we give them. And medications, meaning pharmacological treatment, really is second line. And we looked at giving it rather than scheduled morphine, it's given just as a PRN, or they call it like a rescue dose to start if that baby's really starting to escalate and no longer can be consoled well. And a lot of times those PRN doses would be a lot less frequent, and would just kind of get the baby over the worst of that moment, and they'd be able to settle back in with the non-pharmacological supportive care. And the best part, I think, about Easy Console is that it's the parents doing it, right? We're just there as coaches and support people. If that baby needs medication, we're able to provide that. But we're really looking at centering our care around that family rather than just focusing on the neonate and not involving the birthing parent. I'm going to pause and make sure that this question doesn't apply directly to the screen. We can answer questions at the end too, but. Oh, great question. So what kind of support is available for a family after they're discharged from the hospital, but if mom has to be readmitted? So quite often in this case, we would have, like support as far as inpatient goes for the parent, but we as inpatient, I'm looking at just the inpatient side of this for Virginia Mason Franciscan Health, don't have specific resources available directly to the family. But I do know that there are a lot, we try to get them, into that like Help Me Grow program that you just explained, which was amazing, and plugged into other resources that can provide them that outpatient support before they get discharged from the hospital in the first place. They also have support they're plugged directly into a neurodevelopmental care follow-up clinic as well. And please let me know if that didn't fully answer your question. We can come back to it. But basically we found that Eat, Sleep, and Soul is really centered around caring for the family. And so we decided that this was going to be the best method for us to try in our system of hospitals to try and shift the narrative from baby and like very withdrawal symptom focused to something that's much more holistic, and looking at whether or not that baby can function. So let's talk about how we implement it. You want to do the next slide. This is kind of similar to what I was saying, is that the parents of the treatment, right? The birthing parent or the caregiver, and their support people, they are the primary treatment. So we're keeping mom and baby together, which means they are in couplet care, on postpartum, being cared for by trained staff who are trained in Eat, Sleep, and Soul and neonatal opiate withdrawal. But they're not in a NICU environment, right? We're going to try and maintain that rooming in and making sure that they're in their own private room as well. We utilize non-farm management as the first line of treatment. So as much skin to skin as possible, breastfeeding if appropriate, per policy if mom's in medication-assisted treatment, etc. making sure we have all the ways to keep a calm, quiet environment that are soothing and not overstimulating for our babies. So making sure that we have signs on the door for volume, right? Not letting a ton of visitors go in and out and being disruptive, or clustering our own care, meaning when we need to go in and help, do vitals, assessments, etc., that we're not in and out of the room all day long, that we're going all in as a team rather than one at a time. And trying to really provide an environment that's conducive to that mom and that baby being able to manage this together. And then a big piece of this is collaborating with the whole team. So the multidisciplinary team for treatment decisions means we're not, just going, okay, this score, we talk to the provider and the provider says, okay, give them morphine, and that's that. We implemented what we're calling team huddles. And so if a baby's score starts escalating, that includes the parent, the nurse, the bedside nurse that's caring for them, the charge nurse on the unit, preferably the provider, the pediatric provider for the baby as well. We'll all huddle together and say, hey, have we optimized all the ways that we can care for this baby before giving pharmacological treatment? And if we identify ways that can be improved, we try that first. And then if the next score is still elevated at that point, we might consider pharmacological treatment. But it essentially means that we're all on the same team, and the most important player of that team is the birthing parent and their baby. And it really helped us function, focus on function and comfort rather than looking all those little tiny signs and symptoms of withdrawal. We're looking at whether or not our baby is able to be a baby and is comfortable doing those things. So the next piece of implementing was looking at how we rolled it out. And so if you want to hit our next slide, please. We implemented Eat, Sleep, Console just on the cusp of the COVID-19 pandemic. So it was really early 2020. Started at St. Francis and St. Michael's in February, and then we finished rollout at St. Anne's by the end of the year. COVID kind of made some things pause for a minute, as you are all aware, but we still, went ahead with the rollout at all of our sites. We really wanted to provide better quality of care to these families, and then we wanted to look at whether or not we're able to help reduce length of stay for those babies and reduce their morphine exposure in this population. So our next slide is the key driver diagram. Thank you.
Wiebe, W-I-E-B-E.
Oh, sorry, is there someone there?
Robin, R-O-B-Y-N.
Robin, could you mute, please? Thank you. So I apologize, it's a little blurry. They wouldn't give me access to the original slide, so I had to screenshot it for you. But this is our key driver diagram, and our goal was just to try and implement about 50% of these families by May, which was a few months after initial implementation. We far surpassed that. People really took this and ran with it. So I believe in May we were at like 90% implementation, and it was only because one of our sites hadn't gotten a rollout. But the biggest challenges that we saw, the balancing measures, were, parental stress and nurse dissatisfaction. And I'll talk about a little bit more about that in a minute. But there were a lot of ways that a lot of angles we took at this. A lot of it was staff education, right? So making sure that they understood how the ESC scoring works, how to really shift that narrative from, the staff are the ones like scoring and making decisions, to the parents are the ones helping us score and helping with those decisions, and really being the first line of care. And then we did that with a huge rollout for education. So we talked not just about, Eat, Sleep, Console, but we did the whole entire spectrum of, perinatal substance use disorder, talked about what these families struggle with. We discussed, trauma-informed care, and why a lot of these, how a lot of these situations kind of come from trauma, to try and really get our nurses to understand the situation that this family is facing coming into the hospital, instead of just looking at the point from birth forward, trying to get that full context. And I will say, I actually received that education. I was still on staff at St. Francis at the time, and it was an amazing rollout. I have to give kudos to both Heather Olenek and Jenny Holbridge. They did an amazing job working together. They rolled it out at St. Francis as a pilot site, and then they actually expanded it regionally to all of our sites because it worked so well. We had to make sure that we had enough, environment that was conducive for this as well. So have enough couplet care rooms, have the ability to monitor babies if they needed to be on monitors centrally when they're still in a couplet care environment, and then maintaining environments that are conducive to supporting Eat, Sleep, Console, right? So can we make sure that the unit stays quiet? Can we darken the room? Can we have our white noise? Do we have enough baby swings for the parents to be able to use that if they need to put the baby down, right? Because they can't safely to hold them and sleep at the same time, all of those things. So we had to make sure all of those resources were available. And then we got a lot of really great support from our executive sponsorship, all the way up to like our regional director at the time for all of our birthing hospitals. And they really helped roll this out at like a top down and bottom up. So staff are the ones that came up with this idea, but they brought this up to the top level so that it was actually cascaded out to all of the sites almost concurrently within a few months. And the biggest key lever to this I found was making sure that the staff had resources to provide support and education to parents upon admission. And that can be really difficult because, you know, a parent is generally admitted in labor in a lot of pain and sometimes already withdrawing themselves. And so, you know, we don't, at that moment is not the best moment to have this discussion, right? But if they're admitted for an induction per se, or they come in and they're not in a ton of pain, or they've delivered and you have that, you know, a couple of hours with them one-to-one on labor, we found that the best moments to really have that conversation of here's what, you know, here's the potential, you know, expectations of what your baby might experience. And here's all the ways that you can help them manage that. And here's the ways that we're going to support you in managing that. And if we set those expectations and provide them that support and, you know, start to really create that therapeutic relationship with them early on in their admission, those are the families that we had the most success with East Console, you know, rollout. And so, you know, it wasn't all daisies and roses. There were some significant challenges. So if you don't mind going to the next slide, please. A big part of it was, you know, just staff education. So there was some confusing on like, what does eating appropriately mean, right? If it's a preterm baby, they're not eating appropriately because they're preterm, but like, is it also withdrawal? And when should we score that baby? And when should we not? When do we initiate a PRN dose versus scheduled dosing of morphine? And that was on both, you know, the staff nurses and providers, you know, that discussion, because it was a really big shift in culture from going straight to morphine, you know, flipping the lid on that and saying, we're going to really start doing everything we can to support these babies before we get to morphine. And so like, where is that line? And that just took some time and lots of discussions, both at the local hospital level, but then we brought this to our QI meetings as well and have these discussions at the regional level, where like what each site was doing and how they were facing that. A big piece of it, like I said, was parent buy work. Sleep Console really doesn't work without caregivers being really involved and enthusiastic about it. And it can be really challenging if those parents, which most of them aren't prepared for this, right? They don't know what their baby might experience. They don't have the support and resources they need themselves. They might already personally be experiencing withdrawal. And so making sure that they had not just education about how to care for their baby, but that they were set up for success. So if they were interested in medication-assisted treatment, we got them into that inpatient prior to their own discharge as a patient. We hooked them up with resources. We made sure that they had support people, that they weren't the only caregiver for this baby, because if any of you have cared for a baby who's experiencing opioid withdrawal, it can be very, very challenging. It's especially challenging to do 24/7, 7 days a week for weeks on end. And that's what we're asking our parents to do. And that's unrealistic, right? So we need to make sure that they have support set up and that they know we're there to support them. So if they need to go to appointments, if they need to go to meetings, if they need to go get their medications from the pharmacy, you know, whatever, if they need just an hour to go outside and breathe fresh air that isn't the indoors of our unit, you know, we are there to support them in that, and we are part of their team. We just need to make sure they know to communicate with us ahead of time so that we can be ready to support them and to give care to that baby when they're not on site. And the biggest, I think, rollout and challenge is just implicit bias and stigma around this patient population. And that is for all of us on all angles of the care team that exists. And I think something that our educators, Heather and Jenny, did a really, really beautiful job is calling that out immediately early on in the rollout phase of this in the staff education, is that we all have these, right? We all have implicit bias and stigma. This exists. And so let's talk about it and let's kind of reframe this and let's get some patient experience. One of my favorite education tools I've used as an educator for this patient population is a video that was made, and I will have to get you the reference because it's escaping me, the company or the organization that created it, but I know it was local to Washington State, and it's basically a patient's perspective. This is a mom who went through two very different experiences, delivering her two children early on. Her first pregnancy, she was homeless, She was, actively experiencing substance use disorder. She was very young. She was 19. And this was much earlier than needs to be consoled. And she had a very negative experience in her delivery, and never really even got to hold her own baby. And the second time around, she's, in recovery, and she is a supportive network, and it was planned pregnancy, and they got to use Eat, Sleep, Console. And she said it was night and day. And just hearing her experience, right, as a human, of what that was like for her, and also what her background was and her history and why it happened that way for her, is so impactful. I mean, I have watched this video probably 6 or 7 times in doing education sessions. And every single time I am just so moved. And I can, it's one of those things that you can see in the audience's faces, that switch of like understanding and empathy, and seeing this person as a whole entire human, right? And this family as an entire unit, rather than just looking at this like microcosm of the situation that you see in the inpatient side. And so that, I think, is still something that we're working on. It's not something we're ever done with, right? Is reducing our own bias and stigma. But the more awareness that we can bring to it, and the more that we can talk openly about it, and the way that our own histories play into the way that we give care to these families is so important. And so that's something we have ongoing. We actually are doing like health equity education sessions at our sites currently, to try and reduce that, and really look at how we can do even better. So those were some of the initial rollout challenges, and there have been some ongoing challenges as well. I'm going to hit the next slide. So a lot of it is just, can we get appropriate withdrawal management for the parent, right? So some birthing parents are just not able to commit to assisted treatment. They're not interested in it. They're not in a moment where they can make that change. And they experience significant withdrawal inpatient, right? And so they end up either leaving AMA, not able to care for their babies, etc. And so we really, I think, still have a lot of work on the parental side of things for maternal management, prior to, during delivery, and especially in the postpartum phase, to make sure that they have the support they need to be able to do Eat, Sleep, Console, because they have to be in a place where they can function, right? And if they're not functional as their own individual, there's no way they can care for another a baby experiencing withdrawal as well. Some of the other ongoing challenges are more hospital related. So it's just staffing, right? If a parent isn't able to room in, if they do leave AMA or whatever the reason be, it's really difficult to have, like, these babies need one-to-one care. And most often our NICUs, especially our special care NICUs, our smaller sites, we don't have the ability to pull one nurse to just care for this baby directly. And so we've gotten creative around that, about how do we implement, whether it's care assistants, like nursing assistants or volunteers, etc., to do a lot of that like non-pharmacological care that these babies need. But we just need planning time to be able to get those resources in the places that they're needed. And so that can be kind of challenging. We're still working through a lot of that. And then some of it is just bed space, right? So if we don't have private room, like we don't have a postpartum room available, Eat, Sleep, Console is really difficult to do in an open bay unit, like a special care nursery. And I would say that's the majority of our special care nurseries in our system are open bay, which means, there's like nice little curtains that we pull for privacy, but that doesn't really do much to dampen those extra stimuli like noise, light, etc. And so we all know that like that's really the primary care that we need to give those babies, and that's not ideal in a space that isn't a private room. So that's always something that we do prioritize, making sure that these families get a private room when immediately. But if the parent is discharged, it can be difficult to hold an entire postpartum room for a really prolonged stay if the like exploding, which has happened a few times in recent times. So those are ongoing challenges. What I think is really interesting is I did a deep dive into our data a couple of years ago. I haven't been able to update it because it is literally like manual chart review. So I've looked at every single Eat, Sleep, Console babies chart from 2020 to 2021, or 2019 to 2021. But I think it's really powerful to see data, to see the change, and that keeps people engaged in this work, especially on the inpatient side, and motivates them to see that we're making not just a difference for that one-to-one, for that one family they're caring for, but we're making a really big difference for this entire patient population. So let's go ahead to the next slide and we can take a look at that. Huge decrease in NOW's cases treated with morphine. So it doesn't look as a total amount from 2019 to 2021, but what I think is especially valuable to see here is that we, previous to Eat, Sleep, and Soul, all morphine given was scheduled, meaning that baby got it every 3 hours, 24 hours around the clock, for weeks at a time for their entire length of stay. And the switch to Eat, Sleep, and Soul, PRN dosing is an option. And so in 2020, more than half of our dosing was PRN. In 2021, it kind of evened out to be about 50-50. But what that really tells us is only about in 2019, 26% of cases of Eat, Sleep, and Soul, or of opiate withdrawal cases got morphine treatment, and it was all scheduled. In 2020, 12% was, but only about I think it was 5% of that was scheduled. So we went from 26% to 5% of cases with scheduled morphine. And in 2021, it balanced out a little bit at about 12%, but still a really significant reduction in scheduled morphine treatment. And those PRN doses were most often 1 or 2 doses for a baby. It was very few needed. And so the overall cumulative reduction in opioid exposure for this patient population was really significant. On our next slide, we can also see just by sites. So that was our aggregate data for our entire region. We have multiple sites within the region that rolled this out, and that data was available for, and they all kind of have unique things about them. So the thing that I thought was amazing is St. Anne and Burien went from all scheduled to all PRN doses for morphine. St. Francis was almost about 60-70%. That's where I was. St. Joe's also went down to 50%, and they're our largest hospital. They have 1,000, correct me if I'm wrong, my St. Joe's friends that are on the call, but about 4,000 deliveries a year or something like that. A lot, many, much more than our community sites. And so they, I think, have the most aggregate data, which is interesting to look at. So they are most representative of our regional data as well. And St. Michael's had a really significant reduction in just giving morphine in general. I mean, they went from about 50% down to below 40% at 2021 of giving morphine. And of that, only about 20% of it was scheduled. So I think there's just really there's power here in this data that shows that, we were probably over medicating babies previously that didn't really need that prolonged exposure. They just needed a little bit of a dose to get over a really rough time, then to be able to function normally and do well. And the other piece of this that we wanted to look at was length of stay. So our next slide, you can see all the different sites and our average length of stay. But at our system, we did have a reduction in length of stay. It was such a short period of time that it doesn't look statistically significant yet. But I'm really excited to look at the data for 2024 and see if there's been a significant shift. Now that it's been over 4 years, we have a lot more data to look at. But the challenge to some of this data is that I was not able to throw out some of the outliers. So there are some, length of stay isn't just a reflection of morphine and sleep and soul treatment. It's also our, premature babies. So I wasn't able to tease out all of the preemies from this data, which I think would be even more impactful to see the difference in our term babies' length of stay, the ones that we expect to go home earlier, right, if they were not experiencing opioid withdrawal. That will really show us, I think, a more powerful shift. But you can still see in some sites, especially like St. Michael's, for example, their length of stay went from about 12 all the way down to 8 in 2 years. That is a really significant drop. And all of our sites look improved, although except for St. Anne, which is interesting. I still haven't figured out why theirs is longer. I'm guessing maybe they had a few more preemies because we also decreased our gestational age that we care for in our community sites during this time period. So there's some confounding issues here, but yeah, so far it's been a really, it's still a challenge. There's still lots of things that we're working through with Eat, Sleep, and Soul and caring for these families in a way that's supportive and making sure that they're connected to all the resources that they need before they leave us in the inpatient side. But I think that there's real power here in what we're doing and that we finally started shifting the narrative towards caring for the entire family. And that's all I had. I want to make sure I catch up with the chat. Thank you very much for having me. But let me see if there's any questions I didn't address.
There's one question that I can read. Do the hospitals provide rental assistance and gas vouchers to parents of new babies that aren't able to work due to hospitalization, long stay after giving birth, or father's baby, or father's unable to work?
Yeah, really great question. I know we help provide transportation assistance to help them get to and from appointments if they need it. We do connect them with social workers that get them into programs that can provide assistance. So we don't have like direct rental assistance, for example, or direct like, housing assistance, all of that we can provide on the inpatient side. But I know our social workers really work closely with all of our community partners to help them get connected to those resources that they qualify for before they get discharged. So that's one of the first things. We have like an order set that we use for these families when they're admitted. One of the first orders is like consult to social work, and we give them the information why, and we make sure that they see the birthing parent prior to the birthing parent's discharge, and then they continue to touch base with them throughout the admission for baby as well.
Thank you. We have a question from our epidemiologist at the health department that I really think would be a great question for you, Emma, as well as Kate and Alissa, and from the previous presentation on plan of safe care. And I really think it's really exciting to think about the ways, I mean, one, the way you all are talking about caring for families that are impacted by opioid use disorder is with such love and kindness and compassion. And this question, I think, really speaks to like what kind of impacts are we seeing on the county overall? And so I'm curious for all of y'all's take. But so this is Ingrid's question. It sounds like these two programs, Eat, Sleep, Console and Plan of Safe Care, were being rolled out in Pierce at similar times. Do you think that they interact in any meaningful way, giving additional benefits because they are both supporting the same population in terms of longer term outcomes for either mother or baby?
I mean, short answer is yes. I think and it's interesting because these were developed like, in parallel play concurrently, but not intentionally interactive. And when I heard about the plan of safe care, when I went to one of their rollout presentations, one of the few that they did in King County, and I was so excited, like that I was just like lit up. I was like, this is exactly what we've needed, because I think they are the outpatient complement to the inpatient piece that we had been trying to get going. And that is something, I think, that interface of, community and inpatient resources has never been very smooth. Let me put it that way. That has always been something that we struggle with. And I know, like on the inpatient side, I mean, as a staff nurse, I was not aware at all of what those community resources even were, because our social workers kind of handled all of that. And so I think just having more awareness at the staff level of what that program is, how it works, how we can message it together as a team, both on the inpatient and on the community side, so that these families feel supported in the way that we want them to feel supported, and not like they are, being judged or punished. Not that it's punitive in any way, has been amazing. I've seen a huge shift in just the reception that parents have, both for both programs. Because of the way that we're talking about it. And it's as simple as that, right? Like, we just need to get down on the level of saying, like, we all care about you. We care about you here in the hospital. Everyone cares about you when you get home as well. And here's the ways that we can make sure that you have the support you need to be successful here. Because I mean, I don't know how many of you are parents. I'm a parent. It is not a one-person job for just the like lowest risk, non-challenging couplet, but it's especially like, this is something that really does take the entire community to support these families, and they deserve and need that support. So I'm so excited that these programs were concurrently developed, and I definitely think this has made a huge difference in this population. But I would really love to hear from someone experiencing that from these, these people that are in these programs. I would love to get more of like the community aspect of what their experience of it has been, and the differences. And that's something we haven't been able to do yet, is really get down to that like patient experience piece of it. We did see our patient experience scores go up, but it wasn't, that's such a huge aggregate amount of data. We don't really know specifically to this patient population. We'd be really curious about it.
Thank you. Kate, in our last minute, I wonder if there's anything you want to share on that question too.
Yeah, I think, it's been really helpful to kind of have these two programs rolling out concurrently, and just like to get that conversation going, kind of like you referred to. There's a new kind of way to talk about substance use and people that are parenting and pregnant who are dealing with with the SUD and just kind of a more compassionate model. So I like to think that plan of safe care might be part of that overall compassion model that, you know, we're moving towards. I know plan of safe care, the evaluation and the data is still kind of coming together to see what the impact has been, but I can say that we're seeing more and more referrals towards the community pathway every month. And right now we're seeing the most referrals that we've ever seen. So that's really exciting to kind of see. We have no idea, we have no way of knowing like who, you know, how many numbers are going towards the portal and might be going towards CPS, but we know that the numbers that are coming our way are increasing significantly. And I think the data is showing that less families are screening in for a variety of reasons. So yeah, I mean, I think the impact is there, and I'm excited to see as we get more robust data moving forward.
Well, thank you so much for your insight, Emma. That was wonderful. Kate, thanks for chiming in at the end here. Annie, thank you for being here. All the presentations today were really amazing. The work that is happening in Pierce is really exciting. We have, as we said at the top of the meeting, there is going to be a conference, in-person presentations on October 21st. We will be sending out information. You can learn more about that. The registration has not opened yet. And then we'll have our next virtual meeting on December 9. And we have a survey for you to give input and what comes to these meetings and who's coming and what information you want to learn. So please take a quick moment and complete that survey that's on your screen right now. And thank you so much to our speakers and the work you all are doing. Thank you all for the work you're doing to protect families in Pierce County. We appreciate you all so much. I hope that you all have a great rest of your day. Thank you.